Hi, everyone. This is Sharina Hagans with the National Center for Medical Legal Partnership. I would like to welcome you to our second virtual training in the SDOH Academy series. Today we have an excellent panel, and I'm looking forward to introducing you to them in a second. Before we get started, I just wanted to give some background information on how things will run today. Next slide. In case of any technical difficulties, please just enjoy what you can. We're going to be able to give you this recording after the session wraps, and you'll also have an opportunity to access the slides, which I put in the chat box. There's a link to the Dropbox, and you can just download the PDF of the slides as well. Next slide. And this is just an overview of some of our goals and objectives. Some people on the line have already joined us for our first session, so we did a deeper dive into this. But you can see that this is a coordinated approach to the SDOH Academy, and we have a lot of our different NCA colleagues that will be offering some of their expertise on these mini sessions. We have 6 total. Today is the second one again. We had the first one in January. If you need an access to that recording, please contact me, and I can get that to you offline as well. Next slide. And this is a list of our faculty. We have a great, robust roster of our national cooperative agreements that are working on SDOH Academy this year, and you'll be able to hear from all of these throughout the 6th session. Next slide. All right, so without further ado, today's virtual training is collecting data on patient SDOH and interventions that address them, and it will be presented by NAC, Health Outreach Partners, and APCHO. So we have Michelle Jester, Kristen Stomanoff, and Twin Tran. And I'm going to go ahead and pass it right over to Michelle so we can get started on this content. Michelle.
Great. Thank you, Sharina. Welcome, everyone. So as Sharina said, I am Michelle Jester. I am the research manager at the National Association of Community Health Centers. And I'm very excited to talk to you all about work that we've been doing in partnership with APCHO, who's also on this webinar, but the Association of Asian Pacific Community Health Organizations, and the Oregon Primary Care Association over the past several years to help organizations collect standardized data on the social determinants of health using a tool that we developed known as PREPARE, which stands for the Protocol for Responding to and Assessing Patients' Assets, Risks, and Experiences. Now, many of you are likely already doing things around social determinants. Some of you may have like a general sense of the social determinant needs of your community based on your interactions with your patients. Some of you may have providers who input like open-ended notes in the social history section of your EHR. Some of you may use paper tools to assess the social determinant needs of your patients. This is all great work, but we think that it's much harder to really act and capitalize on this work without the use of standardized data. So we would really encourage you guys to collect standardized data on the social determinants that your patients face. You can use this data to improve your current efforts around social determinants, inform next steps on how you can build upon your social determinant efforts, inform care and community transformation, and improve population health management. If you can better understand the barriers that are impeding your patients' efforts at healthy living, you can provide better and more appropriate care that meets their needs and their circumstances. And if we provide better care and document in a standardized way the extra time, the extra care, the extra services that we provide to take care of our patients, the more data we will have to make the policy case for different payment systems to reimburse and sustain non-clinical work and for risk adjustment purposes. So again, the more standardized data that we have to demonstrate just how complex our patients are and how that necessitates different types of care to meet their needs, the more we can do to advocate for different payment systems to reimburse those different types of care and then not penalize providers for serving more complex patients. So this, we hope, will really lead to a more sustainable and integrated care system. So today, we're going to talk to you about the importance of standardized data on social determinants and then enabling services, how the standardized data can be used to improve care and inform policy, payment, and community transformation, and then highlight some tools that would allow you to collect standardized data. So next slide. So the first tool we're going to talk about is the PREPARE tool. So as I just mentioned, PREPARE is a national standardized social determinants of health assessment protocol built into several electronic health records that is designed to help organizations collect standardized data at the patient level on the social determinants of health that they face. PREPARE, as I stated earlier, stands for the Protocol for Responding to and Assessing Patients' Assets, Risks, and Experiences. And we chose that name very purposely because Prepare to us is not just a standardized screening tool, it is also a protocol for action and how to build capacity to respond to social determinant needs. So to that end, we've developed a Prepare implementation and action toolkit that I will show you later on that provides chapters that walks you through the steps that you need to take to implement Prepare, analyze and use the data, and then respond to needs identified. So this toolkit also shows how you guys can customize your Prepare implementation to find workflows and implementation models that would work best in your own setting. Next slide. So Prepare has 16 core domains and 4 optional domains, as you can see on the screen. So core domains are those social determinants that we think is important for every organization to collect data on. Optional domains are there for communities where these issues may be priorities for them, so you have the option to collect standardized data on them. For health centers, which I know many of our viewers are, 9 of these domains align with UDS measures. So if you collect uniform data system measures at check-in or at other points in the clinic visit and input it into different parts of your EHR, like for instance your demographics section, this data will automatically populate into the Prepare EHR templates. So just to reiterate, you do not need to ask these measures twice. The data will map into the Prepare EHR templates, but we think it's important to incorporate those demographic measures just to give you a more fuller sociodemographic picture of the patient. You can find the paper version of the Prepare tool along with the Prepare EHR templates at our website at nac.org/prepare. We also have a version of Prepare translated into Spanish that you can also find on our website, and we are working on adding additional translations. Next slide. Many of you may be thinking, like, why should I use Prepare out of all the tools that are out there? Or maybe you're already using a tool and you might be wondering, like, why should you make the switch to Prepare? There are lots of reasons why we think Prepare is unique and popular among the tools out there, but it really kind of starts with our development process. So our development process was both evidence-based and stakeholder-driven. We spent an entire year developing Prepare, conducting an environmental scan of the literature to see which sociodemographic factors were associated with poorer health outcomes and higher healthcare costs. We also conducted a scan of existing tools out there, most of which were only in paper form, so hardly any existed in the EHR at the time, back in 2013. And many of the tools were homegrown tools, so again, not really standardized across organizations. We examined over about 50 existing tools at the time and interviewed about 24 of those to learn more about their approach, their measures, and their use. From that, we really kind of helped inform the development of Prepare. Prepare was really developed before a lot of the tools that currently exist, like the Accountable Healthcare Communities tool, but we tried to make a very good effort to align and monitor other national initiatives that were going on at the time. So we were monitoring and aligned with Healthy People 2020, the meaningful use measures on which sociodemographic factors should be collected in the EHR. We monitored the IOM. We aligned with ICD-10 codes where they existed, and we also monitored the National Quality Forum on which sociodemographic factors should be included for risk adjustment. And we monitored and aligned with these national initiatives because we wanted to ensure that if you had other requirements or other initiatives that you were following, we didn't want you to have to collect pretty much similar data at multiple times. We wanted to align such that you really only had to collect data once. And we also wanted to align Prepare with the ICD-10 codes where they existed to really add an extra layer of standardization and codification. And then finally, what's really important with our development is that throughout this development process, we engaged a group of about 20 health center and healthcare stakeholders, including patients, to ensure several things. One is to ensure that we were focusing on priorities of communities. 2 is to ensure that questions were worded in a sensitive way so that it was comfortable for a patient to answer the questions, in addition to a staffer having a conversation with the patient about these conditions. So sensitivity was very important to us. We also wanted to make sure that measures that were included in Prepare were actionable so that we weren't asking organizations to collect or patients to provide information that really couldn't be done, like nothing could be done about it. And then finally, we wanted to ensure that the tool wasn't too long or too burdensome so that it could really fit within a clinic workflow. So once we applied all those criteria, we had the list that I showed you on the previous slide. We had a health literacy expert review all of our measures to ensure that they met a 4th grade reading level. And then we then conducted cognitive testing with patients to ensure that they understood the questions and felt comfortable answering them, which we found that they did. And they actually really appreciated being asked these questions. We then worked with 4 teams of health centers and health center networks to build Prepare into 4 different electronic health record systems. So those were eClinicalWorks, NextGen, GE Centricity, and Epic. And we worked with them to not only build it into the EHR, but then test Prepare in different health center workflows. We modified Prepare based on those lessons learned from the pilot, and then we released it along with our Prepare Implementation and Action Toolkit back in 2016. Next slide. So some other reasons why we think Prepare is really unique. As mentioned earlier, Prepare is a standardized tool with Prepare measures mapped with ICD-10 Z codes. And most of our EHR Prepare templates automatically have ICD-10 Z codes pop up when you select a certain Prepare response so that the provider or the staffer can then decide if they want to add those Z codes to the problem list. As I just talked about, Prepare is evidence-based and stakeholder-driven. So it was developed, vetted, and tested by your peers and the safety net who would actually implement and use the tool. So we really think it's part of workflow process. It is free, and it comes with free EHR templates and resources to help guide your implementation and response. So you can find the Prepare paper tool, the Implementation Action Toolkit, and the EHR templates are all free on our website. And all of the resources on our website are based on best practices and lessons learned from early Prepare users to really help guide your implementation and use on Prepare. Just so people know, we are working with other EHR vendors to build Prepare into more systems. So Cerner should be releasing a Prepare template at the end of March. And we are also working with Athena, Allscripts, and Greenway. In addition to this, Prepare is workflow agnostic. So you do not need to adhere to a certain workflow model to implement Prepare. Prepare is designed to fit within existing workflows and/or it could be combined with other tools or data collection processes that you may already have in place. Prepare is patient-centered. So Prepare is really meant to help you have a conversation with your patients about their social determinant needs and circumstances. We do not want you to feel that you have to ask each question verbatim, word for word, and en rote as listed on the paper form. Rather, we really want you to build relationships with your patients and have a discussion with them about their social determinants. So because of this, we really advocate that it's important to standardize the need rather than the question. And we believe it's really important to have this flexibility in workflow and administration methods so that patients feel comfortable and so that the implementation process is actually successful and sustainable. So, and then finally, Prepare is widely used. So Prepare is now the most dominant social determinant of health risk screening tool used by health centers, and it's gaining popularity by the day. So most all state primary care associations and health center control networks are interested in supporting their members with Prepare. And more hospitals, health systems, health plans, and other healthcare organizations are using Prepare. But for health centers, we think it's really important for us as a movement to collect the same standardized data so that we can better tell the health center story, who we serve, and all of the ways that health centers go over and beyond to take care of their patients and really demonstrate the value of health centers. Next slide. So here's a screenshot of one of the Prepare EHR templates just so you get a sense of how it works in the system. So this template was developed by the Alliance of Chicago Community Health Services for GE Centricity. And as you can see, kind of where the white bubble where it says add underachievement in school, so as you can see, if a certain response choice is selected, the option to add the corresponding ICD-10 Z code pops up so that you can then add that Z code to the problem list if you like. With these EHR templates, you can track past history, so you can see trends or if social determinant circumstances change over time. Next slide. And then I wanted to show you guys the table of contents for our Prepare Implementation and Action Toolkit, just so you get a sense of the resources that are out there to support you. So this is really meant to help walk you through the steps you should take and the things you should consider to help strategize your Prepare implementation. And again, all of this information in our toolkit is based on the lessons learned and the best practices of our Prepare pilot testers and our early adopters of Prepare. So the first couple chapters really kind of help you understand Prepare and then strategize for implementation. Chapter 4 contains our EHR Prepare templates and then some resources on how to use them. Chapter 5 has a bunch of infographics that highlight different workflow models and then kind of key takeaways and trade-offs with each of them to help you kind of better determine what might work best in your setting. Then we have a couple chapters on how you can analyze and use the data, and then finally the last couple chapters kind of walk you through how you can build capacity to address needs identified by Prepare, has lots of examples of interventions you can use, and then finally it covers how you can track in a standardized way the enabling services that you're providing by using APJO's Enabling Services Accountability Project, which Twin and Kristen will talk about in just a little bit here. And just so you guys know, we will constantly be adding additional best practices and lessons learned and resources as we learn more from the field to this toolkit. So it will be constantly updated with new learnings. Okay, next slide. So now you may be thinking that this all sounds great, but how am I going to fit one more thing on top of everything else that we're doing? So if you were able to attend the first Social Determinants of Health Academy webinar, our colleagues Allison at ACU and Mark from Capital Link really kind of touched on this during their webinar on assessing readiness, that essentially change is hard, and we acknowledge that. However, we really think that incorporating standardized data collection on social determinants and enabling services can really add value to work that you were already doing and will really help make the case to reimburse a lot of the work that you're already doing that currently isn't reimbursable. So in many cases, you can fit Prepare into your existing workflows. In other cases, you may just need to slightly tweak some existing workflows, and then other organizations may opt to develop new workflows. It really just kind of depends on your setting. But we think it's using the CDS 5 rights framework is a great way to help you determine how best to implement Prepare in your own environment. So the CDS 5 rights framework helps you think through those critical questions: the who, the when, the where, the how, and the what questions of workflows and projects. So if we apply this to Prepare, it's first important to think of what information will be collected and what is already collected. So if you're already collecting data, again, like demographics data, I'm sure many of you guys are already collecting demographics data at check-in. You know, where is that data stored and who can view that data? And if you're already collecting it, you don't need to ask these questions again, but simply map to that existing part of the EHR where you are collecting that information. So we really think it's just helpful to walk through each of these questions and prepare to see if you ask that in another part of your visit or for another initiative, or if it aligns pretty well with like a health risk assessment that you're also administering, so that you really don't duplicate efforts. And again, most of the Prepare EHR templates map to existing data in the EHR such that if you collect it at other points in the visit, it will automatically populate into the Prepare EHR template. But thinking through this question may help you consider different types of workflows to collect the data. The next question is who. So who will collect the data, who needs to see the data to inform care, and who will respond to needs identified. So think about who has time to talk with the patient about Prepare and has the skill set to do so, who has access to the EHR to input the data, who has the knowledge and the skills to help respond to needs identified, who may be collecting other similar information for other initiatives or assessments. And also, like, do multi-department teams already exist? You know, you might have a chronic disease management team that you know works well, it's interdivisional, and so it really helps facilitate conversations around data and responding to needs to inform care. So these are just some questions to think about in regards to who. The next question is where. So where are you going to collect this information, and where will you display and share this information? Is your waiting room private enough to administer Prepare, or should it be administered in a private office, such like the staff room of a patient navigator, or maybe in the exam room, but before the provider enters the exam room? Do you have staff who conduct home visits, such as community health workers or health coaches who could administer Prepare at the home? Some things to consider. The next question is how. So how are you going to collect this information, and how will you share it to inform care? Do you want a staff person to discuss Prepare with the patient and engage them in a conversation? If so, would you need interpreters? Or would you want patients to fill out Prepare by themselves using either tablets, kiosks, or maybe using an email or mobile version of Prepare? And then thinking about, will you share Prepare data in team huddles so that data can be used to inform care? Will you share it with your leadership and your board to guide planning and next steps and to gather buy-in? So things to consider in regards to how. And then finally is when. So when will you collect this data? Will it be before the patient comes to the clinic, while the patient is in the waiting room waiting to be roomed, after the patient is roomed but waiting to see the provider, or after the provider visit? So hopefully these questions will help you think through how Prepare would fit best in your setting, and then help you identify either existing workflows or teams that Prepare may add value to. Next slide. So it's really important to remember that there is no right way to administer Prepare. And this chart kind of shows different workflow models that have been used by different health centers and how they can be implemented and the potential trade-offs associated with each. So for non-clinical staff, the benefits of using non-clinical staff is that they often have training to engage patients using empathic inquiry or motivational interviewing techniques. They may have more time to talk with the patient than other staff. They often have relationships with patients, so patients feel comfortable conversing with them. They're often knowledgeable about resources in the community, so they can respond to needs. Non-clinical staff can administer Prepare before or after the visit, so as not to disrupt the visit workflow. So things to consider for non-clinical staff. Clinical staff, so the benefits of using clinical staff is that they have training to collect data on other sensitive information, given their experience with sexual histories and whatnot. They also have opportunities to integrate Prepare into their workflows by administering Prepare after taking the vitals, and they can easily input Prepare data into the EHR as they do so. Care coordinators often have experience administering other health risk assessments, and so they can administer Prepare at the same time. They can also address issues that arise from the similar assessments at the same time. And then finally, there's what we call a no wrong door approach, which one of our pilot health centers in Hawaii really kind of espoused and tested. So this approach essentially says that anyone can be involved in collecting Prepare data and responding to needs. And this allows Prepare to really kind of fit within your existing workflows and allows everyone an opportunity to be a part of the process of, quote unquote, like painting a fuller picture of the patient. So if people are really interested in becoming involved with Prepare, chances are they will be Prepare champions and be highly motivated to collect data and respond to needs. You want these people on your team. So accept all volunteers to help guard against staff turnover and other competing priorities and responsibilities. And then finally, if you would prefer a self-administration method, this can be via email or using tablets or kiosks or using paper. So this is a good way to use time when patient is otherwise just waiting to be roomed or to see the provider. With this method, patients have privacy to provide information, and you can reach a large part of the population in a short amount of time without disrupting clinic workflow. However, with this, we think it's still really important to follow up with the patient to discuss results, and I'd prioritize actions, if any, to help address needs. So just some things for you guys to think about as you consider and strategize your own implementation models. Next slide. We wanted to show you some examples of how you can use Prepare data to inform care and community transformation. We know that many of you guys are focusing on improving diabetes outcomes, so we wanted to highlight examples of using Prepare data for diabetes care management. So what you see on the screen is work that our Prepare partners at the Oregon Primary Care Association have done in using Prepare data for population segmentation with their diabetic patients. So if you start on the left, let's say you start with your general population. You can then segment that population to diabetic patients. You can then segment that population further to diabetic patients with high A1Cs. You could then use Prepare with that target population to gather more information as to what non-clinical factors may be contributing to their high A1Cs. So you may discover that some patients may have transportation issues that make it difficult for them to go to the grocery store, or make it difficult for them to get to the health center or other healthcare organization for their appointments. Others may not be able to afford healthy foods. They might be eligible for SNAP benefits but not aware of it. So with this knowledge, you can really use Prepare data to kind of redesign care teams, to develop or strengthen community partnerships to bring needed services to your patients, or bring services on site for your patients. Some other examples from the field that we've heard is that another health center discovered that many of their diabetic patients felt socially isolated. So as a result, they engaged them in group visits and group classes to really help make them feel more connected with their community. Several health centers have discovered transportation needs amongst their communities, and so they've done lots of different things. So one health center started to bring health fairs on site that also brought in social service partners like SNAP, so that patients could then see all the resources available in their community and then enroll for benefits as needed. Some health centers have partnered with lots of different organizations like churches or Uber or Lyft to provide transportation services to their patients. Another health center has hosted quote-unquote neighborhood health days, where they would bring a mobile clinic and other community partners to the neighborhoods that had few transportation options so that they would actually come to them. And then another health center, they discovered that because the transportation issue was so high in their community, 1 in 5 of their patients had transportation needs. They partnered with the local transportation agency to receive bulk discount rates for bus tokens and taxi vouchers that they could give freely to their patients. So then they also geomapped the data to highlight those areas with transportation needs so that they could advocate for new bus routes to those areas. So just some examples of how you can really kind of use this data. Next slide. So to kind of just recap, there are lots of free resources you can find at our website at nac.org/prepare, including the tool, the toolkit, the EHR templates. We also have some recorded webinars that you can listen to and some FAQs. But in addition to these resources, we will also have lots of training opportunities that are upcoming this spring and summer. We'll have more national webinars on Prepare, implementation, use, and strategy. We're building a peer learning group to help facilitate networking and shared learning between Prepare users. We'll also have some shared learning calls for state primary care associations to discuss key topics of interest. And then we'll have second rounds of our Prepare Train the Trainer Academy and Health Center Engagement Awards with applications coming out this summer. So if you are interested in getting notices on these upcoming opportunities, as well as alerts to new or updated resources on Prepare, please email me. My contact information is up there, so it's mjester@nac.org, and I will happily put you on our Prepare listserv. Next slide. So Prepare, while important, is only really kind of half the equation here. We really think it's critical to have, in addition to standardized data on the social determinants of health, it's also critical that you have standardized data on all of the non-clinical interventions, the partnerships, the services, and the time that you spend to address the social determinant needs and help you prepare for value-based pay environments and make the case to reimburse this kind of upstream work. So to that end, I would really now like to turn it over to my Prepare partner at APSHO, Twin Tran, and my colleague, Kristen Stomanoff at Health Outreach Partners, to talk more about how you guys can collect standardized data on enabling services. Oh, but first we're doing a poll, that's right. So we have a poll on the screen just to see, is your organization already collecting data with on social determinants of health? So if you guys just wouldn't mind taking a minute to fill out the poll. And then Kristen and Twin, I think I'll turn it over to you guys.
Great. I think we are waiting for the poll to finish, and then I can get back to the slides. think we can, Sharina and Kaylin, have you closed the poll?
Just get, in 2 seconds, the poll will be closed.
Got it.
We'll see the results now. All right.
Wow. Great. So it looks like over half of folks are collecting social determinants data in some way. Nearly 20% prepare, nearly half using a different tool, about a quarter are not, and for about 16% of you, it's not applicable. So for organizations like ourselves, the National Cooperative Agreements, for example, that would not be applicable. This is really great to know. So I'm glad to be able to now move it toward the last thing that Michelle mentioned, that we do need data both on the social determinants of health your patients experience, but also those interventions that you are using to respond to those social needs. And Michelle started to allude to this, but as you all know, payers are really more and more holding providers, including health centers, accountable for reaching patient or population quality targets and for lowering costs. But it can be really difficult. It can be almost impossible to improve outcomes and reduce spending unless we provide services that do directly address social determinants of health. It can't all happen at the clinical level. And you also know that this is often best done in partnership with other social services organizations. Our current systems of payment really don't adequately incentivize addressing social determinants of health. We don't have assurance that these programs and these services are sustainable. They're often non-reimbursable. Certainly community partnerships are usually non-reimbursable unless we have a specific contract with partners. But as payers are moving more toward a system of value-based care, health centers definitely can advocate for the necessity of these often unreimbursable services. But of course, in order to advocate for that, in order to push for that, you need data. So as Michelle said, toward the end of her section, it is critically important that you have both data about your patients' broad needs, including social determinants of health, and about the services that you are providing to address those needs. Next slide, please. A lot of the health centers, a lot of the services that health centers provide to address social determinants of health needs are non-clinical in nature. They're those enabling services that really make sure that patients can get the health care they need. But enabling services also frequently address issues that have an impact on health, but issues for which the best solutions aren't a visit to a medical provider. Things like interpretation, transportation, health education, housing assistance, medical legal partnership interventions, things like that may be directly connected to clinic visits, but they may not. Next slide, please. Here are the specific categories that are covered by an existing enabling services data collection protocol, which I'm going to tell you more about in a moment. But looking at this list, I'm curious if anything jumps out at you as services you already provide to help your patients. And I'm going to talk about patients generally and then specifically patients with diabetes. But I don't know if you're able to type in the chat box. Maybe you can type a little quick note in the chat box if you know offhand if your health center is providing social services assessments, case management, referral, financial counseling, health education, all of any of these things. Sharina, would I be able to see if people type a quick note into the chat box or not necessarily?
I can just let you know what people are saying.
Great.
People have income security and health promotion, all of the categories, most of the categories. They also do patient navigation. A lot of people are saying they do everything. And health education, referral, social services, outreach are top responses as well.
Fantastic. Excellent. Thanks. Thanks for participating, everyone. So thinking back to what Michelle shared, and of course, thinking about what you all are sharing right now, a lot of enabling services provided are directly suggested by that SDOH assessment that you're doing with Prepare or with the other tools you're using. if you're using one of those tools, you should be getting a good picture of what your patients truly need to be healthy outside of visits to a medical provider. And so you might find that food security is a problem, or housing is a problem, or family income is a problem. And you can then prioritize the enabling services you provide. For diabetic patients, you're probably already providing a lot of case management, coordinating visits to multiple providers, both at your health center and maybe outside to specialists or to social services providers. You might need to provide transportation services because you need to see your diabetic patients regularly. And if they can't get to you easily, you might currently offer or need to think about how you could offer transportation services. Certainly your patients need to communicate effectively with all members of the team. So if English isn't their first language, you need to make sure you either are linking them to bilingual providers or that you provide those interpretation services. And possibly your diabetic patients are experiencing health-harming legal needs. An example of perhaps someone's electricity was cut off and they need to refrigerate their insulin and now they can't. Perhaps someone was denied insurance benefits. These are things that civil legal aid through a medical legal partnership can help sort out. And you well know that even if they're not seeing a medical provider for these issues have a direct impact on health. So there are all sorts of services you need to provide, and many that you clearly already are providing. But how do you really know how much you're actually doing? How do you know that you've got your enabling services appropriately staffed? How do you know if they're having an impact in terms of patient access and patient outcomes? You really need to do good tracking to know these things. Next slide, please. So you may be thinking, we track enabling services. We have to for the UDS. For those of you who are familiar with the UDS, this slide probably looks familiar. It's a portion of Table 5 in the Uniform Data System, which is a system where all health centers have to track key information on the services they provide and their patient populations, their staffing patterns, their costs, things like that. They're required to submit some information on enabling services to the Bureau of Primary Health Care as a part of their annual Uniform Data System reports. But as you can see on this screen, the UDS really poorly tracks the scope of enabling services actually provided by the health center. You can see that health centers are required to report the number of enabling services staff in various categories. So that first column that's white, well, the first column is all of a handful of enabling services that you might provide. Then there's an FTEs column that's white. You have to report the number of staff in these various positions, but you can only report on the number of visits that case managers and patient or community education specialists are doing. And even reporting on those number of visits doesn't give you any sense of how much time people in those positions are spending providing these services to your patients. So it's a very, very small sliver of the work you're actually doing in enabling services. Next slide, please. So I'll talk to you about the protocol for a moment. And caveat, we do these as a full day training, so we're just scratching the surface today, but there are going to be lots more opportunities to engage. But this was originally begun by something called the Enabling Services Accountability Project, which APCHO and some partners launched beginning in 2004. And they actually engaged 4 health centers serving predominantly Asian American, Native Hawaiian, and other Pacific Islander populations. And the aim of the project was really to fill the information gap that existed around enabling services data. So they created a model, and everyone who participated in the project committed to using a standardized protocol for tracking their enabling services. And they were able to track that data over time, link the data to patients, and they actually saw correlations, relationships between higher enabling services utilization and better diabetes outcomes and better rates of childhood immunization. So it was exciting to see the relationships that appear to exist. There was a lot of health center interest, there still is, in training and support around this, but it was challenging for one organization to manage it all. So APCHO reached out to my organization, Health Outreach Partners, and the National Healthcare for the Homeless Council to collectively develop a training of trainers manual and provide TA to a broader segment of the health center population and not just the health centers that go to APCHO for TA on a regular basis as part of their membership or other. So we've been partnering with them since 2011. And the definitions that you'll see, so on the left-hand side are the categories from that first protocol. There was a smaller number of categories. Folks were collecting data on case management assessment, case management treatment and facilitation, case management referral, all the things you see in the very left-hand column. Over time and with experience tracking data, folks realized that they were doing things a little bit differently than had originally been envisioned. And so we worked with an advisory committee of people who are tracking this enabling services data, and we updated the categories. And so that's the middle column. And in a lot of cases, it shows how much of the enabling services that health centers provide are connected not exclusively to linking people to clinical services, but are also connected to linking people to social services providers. So I am curious, I'm going to ask Sharina to launch one more poll. I'm curious about how many of you have done any of this using the old enabling services definition.
And the poll will stay open for about a minute. We'll keep it open for another 40 seconds or so. Just want to make sure that we get everybody's response in. So we appreciate you taking the time to do this very brief poll. Thank you. All right, about 10 more seconds. Any last minute additions to the poll? And then I'm going to go ahead and view the answers in a second. All right, so the poll is closing now. And Kirsten, you'll be able to see the results.
Great. Got it. Interesting. So a smaller proportion of folks are collecting data on enabling services. 30% approximately are using some sort of data enabling services data collection tool, but only a small percentage are using the APCHO protocol. About a third of you say no, and for about a third of you, it's not applicable. So that's really great information. We've learned from people that we've talked to recently about this, particularly from primary care associations and health center controlled networks. There's a lot of interest and support for this, but we received the suggestion that it would be very valuable if it were connected to training and support around prepare. So that's something that our teams are really thinking deeply about. I'm going to go to my very last slide, and it's just a quick nitty-gritty about process. Sharina, can you click back over to the slides? I'm still seeing the poll screen. Okay. Great. Okay, so for the documentation criteria, again, this is the nitty-gritty about how the data is collected. We have lots more resources. We're going to do follow-up trainings. We have an office hours next week, as you know, so you can come and get your questions answered in a more relaxed format. But two sort of main parts of the documentation criteria. The first is the type of service and who can enter it. So the service has to be provided by a staff member or a volunteer of your health center or a contractor. You couldn't count time that somebody you referred to outside of your health center spent working with a patient. So it has to be stuff that your health center is directly providing, although you can count time you spend making the referral, but that's your work. The service also has to be linked to, in most cases, a medical patient of the health center. But one of the updates that we really did make in the second iteration of the definitions was to make space for people to track more of the community health outreach work that they were doing that may not be currently conducted with an existing patient, but it may cause them to convert to a patient. So we've made space in the resources we've developed to guide health centers on how to do that. And the last part about the criteria is that it generally must be provided directly to a patient or to their primary caregiver. So for example, a service provided to a parent on behalf of a child. But some health centers found that they were spending so much time communicating between the enabling services provider and the clinician that they wanted to track that time. So they made an exception for themselves. And you actually do have a lot of latitude to do what works for you, even as you use this standardized protocol. But in general, you want it to be connected to, it has to be provided to the patient or a primary caregiver. And if you are using that enabling services provider to clinical provider option, it still has to connect back to an existing patient. So then the last thing I will talk about is timing. You could make yourself crazy with this, and you could literally spend more time documenting enabling services than you spend sending them. So the clock starts at 10 minutes. If you're making a phone call that takes you 1 or 10 minutes, we would not ask you to take the time to document that call. But for services greater than 10 minutes, we suggest documenting, and you round based on 10-minute increments. So a 12-minute service would get counted as 10 minutes. A 16-minute service would get counted as 20 minutes. Again, these are nitty-gritty, and we can provide lots of training on it, but I wanted to give you a sense of what does it look like to track these services. And at the end of the day, you have this really clear picture of how much time your staff are spending on this, how much time your patients who meet different socio-demographic criteria, who have different conditions like diabetes, who's using the services the most, and what outcomes might they be getting to. That's down the road, but it's something that over time you can track. So with that, I want to turn it over to Twin because she has a wonderful example of how this kind of data helped a health center improve its diabetes programs. So Twin, I will hand it to you.
Okay. Thank you, Kristen, and thank you, Michelle, before. So my name is Twin Tran, and I'm with APCHO. For this portion of our webinar, I'm going to show you what the enabling services data look like at the health center level, and it really helps by having this data, it helps us and you to build that evidence base for what is effective for our patients and which services are needed, as well as what additional services might be needed to meet the needs that we're seeing. So next slide, please. So this one example that I'm going to share with the group today is based on the health center experience using the former enabling services data collection protocol. So when Kristen had gone over that slide about the old set of definitions versus the expanded set of definitions, because the expanded set of definitions is still relatively new, we haven't had implementation in that, so no data to share on that yet. But so this particular example is really based on that former coding categories. So as part of their patient-centered health home program, this particular site wanted to target intensive care coordination services to those who were considered high-risk patients. And particularly, they had a diabetes diagnosis with a HbA1c level of greater than 8, plus another chronic condition that warranted enrollment into this care coordination program. And then they wanted to assess by using the data collection protocol to see specifically in the care coordination service encounter, what specific things were taking place in the encounter, how much time was spent with each patient, and whether it really supported the patient in improving their HbA1c level. So having the enabling services data really helped them better to see what was going on at the visit and ultimately whether it did support an improved health outcome. So next slide, please. So here you're looking at a table of outcomes information on what it was for care coordination, how much time was spent. So between the period, the year in 2012, the average number of encounter per patient within this intensive care coordination was 26.8. The top 3 enabling service that was provided during those encounter or visits, so CM003 is case management referral. HE001 signifies health education was provided. And then FC001 is that financial counseling was provided during the visit. And you can see that the average time per encounter per patient is 12.38 minutes. So after sort of the end of that first year of data collection, so quality assurance checks were made throughout that first year just to make sure that the care coordinators knew the definitions and that they were really documenting correctly and consistently what services that they were providing and how to document the time encounter. So throughout the year, checks were made. But finally, at the end of that first year, they sat down to look over this data, and what they came up with upon seeing this full year's worth of data was that, we provided financial counseling in the encounter, and perhaps that may not be the best use of our time with the patient. Maybe perhaps they should see our financial counselors instead for matters related to eligibility or enrollment into some programs, some financial support programs. So they made that determination. And then they looked at that 83% of service was out to referral, and they thought more about what does care coordination actually mean for us and for our patients, and should we be making referrals or should we be making more of an effort to use this time with our patient to provide intensive health education services. And so you can see on the bottom row is that 2013 year data. And so you see still about the average number of encounter per patient is a little bit less, but it's still at 26. And then you see the top 3 enabling services were CM002, which is the case management, treatment, and facilitation. CM001 is case management assessment. And then HE001 is health education. And because of that change in the types of services or care that was provided in the encounter, you see that the average time per encounter had doubled, more than doubled per visit with each of these patients. So really that having this data can really help the staff, and even if you're not using, APCHO's enabling services data, I really urge you to have collect enabling services data in a way to help you inform the programs and services for your patients, because it's really critical that we know whether it's effective, and if it's not effective, then we make the change as appropriate so that we could use our existing staff and our existing services in a more targeted way and a more effective way. So next slide, please. So this is the HbA1c results for those patients meeting those requirements that as I had mentioned earlier, who were enrolled in the intensive care coordination program. So at baseline, for patients who were enrolling in at baseline, the average was average HbA1c was at 10.5. The second column, where you see patients' HbA1c less than 7 at baseline, was due to the fact that aside from having a diabetes diagnosis, there was another chronic disease factor that helped the patient meet the eligibility criteria to be in this intensive care coordination program. And then for at baseline, those patients whose HbA1c greater than 9, there were 72% of those patients. But in terms of the post-intervention, so for patients who enrolled in the program and then they get their HbA1c measures 9 months after being in the program, what you can see is that it's the average HbA1c was down to 9.3, and that the percentage of patients who HbA1c was less than 7, they were under control, increased about 13%. So those who were experiencing HbA1c greater than 9, you can see that number is reduced. And so next slide, please. And so they saw they've had that evidence base to really support this intensive care coordination program, but also really to help the health center make some operational decisions as well. I just want to go show on this screen what we are showing here is the example EHR template that from Prepare that Michelle had shared. But at the bottom where the red circle is that link to the enabling services. So if you currently have in-house enabling services to meet any of those needs that are identified in Prepare, what you're going to do is staff is going to click on that template and then choose the service that they provide in the time that they spent. So I was really thinking through thoughtfully about how you're assessing needs, and then if there are any needs that are coming up that you can respond to, that you can document it as well within the EHR. And then I'll go to resources. And I know we're coming up on time, but we have next week at the same time for a chance in office hours for folks to ask really detailed questions of us and the material that we presented so far. As Michelle mentioned, there is the Prepare Implementation Toolkit. And she also mentioned that change is hard. So for Prepare or enabling services data collection, change is very hard. And so we included materials and resources on change management as well within that. Within the Prepare Toolkit, you'll find the Enabling Services Toolkit as well. But if you want to go directly to our Enabling Services Toolkit that Health Outreach Partners and National Healthcare for the Homeless Council had really helped us put together content, you can go directly to enabling-services.apcho.org. And as Michelle and Kristen mentioned, that there's going to be really upcoming opportunities to engage us more deeply and learn more about implementing these various data collection activities. And then I have a contact slide, next slide, and I know, Sharina, you have some additional information for us about the follow-up office hour, as well as the next virtual training.
Yes, thank you so much, Twin, and thank you, Michelle and Kristen, too, for your great and informative presentations today. So I just want to let everyone know that following the session, we have a brief virtual training evaluation. It shouldn't take you more than 3 or 4 minutes to fill that out. Next slide. And the follow-up office hours, again, we have been tracking your questions. Thank you for engaging us in the chat box. We have shared those with our panelists, and they will be responding and getting back to you with those questions answered, and we'll be having our office hours next week. I sent a link in the chat box. You'll also get this as a follow-up in your email, and you can register. They are limited to 30 participants and open exclusively to health centers, PCAs, and HCCNs. I know we have some of our friends from some hospitals and other NCAs and other organizations on the phone camping out, but these office hours are exclusively for those 3 different organization types. Next slide. And our next virtual training is going to be on Thursday, March 8th. So this is a part 1 of 2 cross-sector partnerships that address social determinants of health, and it will be presented by CSH and National Healthcare for the Homeless Council. So you'll be able to register for that session as well. You'll get more information on our website and in a follow-up email. Next slide. And we just want to say thank you so much for your participation today, and we hope that you join us for our upcoming sessions. We have 4 more, so you can get all that information on the SDOH Academy website that I'm going to go ahead and pop into the chat box, and you'll be able to register for any additional presentations that are coming up. And again, thank you so much for sending your questions, and we'll be able to get to those and follow up with you offline. Have a great day.
Thank you.